Welcome back to Pediatric. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
Well, Alice, we have a treat today. Today, we're discussing all things extracorporeal liver support. It can be SPAD, MARS, CRRT, TPE, therapeutic plasma exchange, a multitude of options, and we have quite the expert to share with us how to implement these.
Yes, going right into the Rolodex of terms, we've got Ayse Akcan. Dr. Arikan is a dual-trained pediatric intensivist and nephrologist and Associate Professor of Pediatrics with tenure at Baylor College of Medicine. She works at Texas Children's. She is the Associate Research Chief of the Division of Critical Care Medicine as well. Dr. Arikan is a clinician-scientist whose research focuses on the recognition and management of acute kidney injury in the critically ill, pharmacodynamics and extracorporeal therapies, management of multi-organ failure, as well as sepsis, resuscitation, and outcomes. Dr. Arikan also serves as the medical director of the critical care nephrology and inpatient dialysis, and she's the medical director of the Extracorporeal Liver Support programs at Texas Children's. We are so lucky to be sitting down with her today. She is an absolute wealth of knowledge.
Yes, let's get right to the episode. Welcome back to the Pediatric podcast. We are so excited today to be sitting down with Dr. Ayse Akcan. To get things started, will you please tell us something about yourself and include something you enjoy outside of medicine?
Zach, perfect pronunciation. Well done. I'm Turkish, so therefore unusual spelling and unusual pronunciation of a very typical Turkish name. I was thinking about this. I always blank for whatever reason when asked about a fun fact about me. I've decided I like fast cars and I'm a big Formula One fan. And I once actually volunteered at the medical tent in one of the Grand Prix. And I would love to go see the Monte Carlo, the Monaco Grand Prix one day. That's one of my bucket list items.
That is awesome. I can't believe you were medical personnel there. That's so cool.
It was cool. Unfortunately, or fortunately, none of the drivers came.
Yeah. Could be really critical. So you specialize both in nephrology and critical care. How did you make that choice? What did this pathway look like for you?
Love this question. The answer is convoluted, just as my pathway was. I never really set out to do anything other than peds critical care. I knew when I was a second-year resident that I wanted to work in critical care. But this is back in the late 1990s, early 2000s when I'm training, and it seemed like every septic shock patient ended up with multiple organ failure and needed to be on CRRT. And the only thing I actually wanted to do, the adventure started with me wanting to learn about CRRT. So it became what was a 1-month elective for multiple reasons, became a year of critical care nephrology fellowship. Then I fell in love with nephrology and decided to do nephrology fellowship on top of it. So technically I have 2.5 fellowships.
That's amazing. Life doesn't always take the direct route, and sometimes the meandering, the wandering is one of the best parts.
Correct. And extracorporeal therapies have always been near and dear to my heart. And I was an ECMO physician until very recently, and I've specialized in all the other extracorporeal therapies. So I really feel like I found my niche in terms of my area of interest in medicine.
Yes. So our topic today is extracorporeal liver support, all the various modalities. Will you tell us what got you mostly involved in that area specifically?
We are a very big liver transplant center, as you might be aware, Baylor College of Medicine, Texas Children's Hospital. We're usually one of the top 3 transplant centers in terms of our volume and tend to take on a lot of very complicated patients. And even though we were trying to deliver the best possible care to these patients, we recognized as a group of individuals interested in patients with acute liver failure and acute on chronic liver failure that their mortality was very high, especially if they were ending up on CRRT, developing hepatorenal syndrome, and recognized that we probably were not delivering optimal support, organ support through CRRT alone. And we had started a program modeling after the Far East and Australian centers where organs tend to be scarce, using CRRT in tandem with TPE. But even though our mortality experientially had improved, we still could not support these patients, especially through their severe hemodynamic instability. As you might be aware, taking care of these patients, critical liver failure is the perfect role model for multiple organ disease in the ICU. Liver fails and almost every organ fails. And hemodynamic instability, high output cardiac failure, and in ACLF, acute on chronic liver failure patients, cirrhotic cardiomyopathy is a huge component of the driver of morbidity with shock state. And that was very difficult to treat using CRT and TPE tandem. So we were looking for what was available. And one of the platforms that have been FDA approved for a long time in children for intoxication had just gotten FDA approval for hepatic encephalopathy in adults. This is the platform called MARS, Molecular Adsorbent Recirculating System. This is a proprietary term. It is now owned by a vendor, but essentially what it refers to is albumin augmented CRRT, so enhanced clearance. And it made a lot of biologic plausibility. It made a lot of sense because there's a lot of toxins that actually accumulate in liver failure that are protein bound that regular CRRT, even high volume CRRT, will not remove because of the nature of the toxins themselves. So we decided that we were going to add MARS as an additional therapy for specifically hepatic encephalopathy to our armamentarium, and quickly recognize that on its own, none of these therapies are sufficient. So they need to be used in conjunction with one another, and launched our program, which we call Hybrid Extracorporeal Therapy, or HET, that I think you guys have seen, we published on before, that we use uniquely in our institution. It's really not a specific platform or machine. It's the innovative use of existing machines in order to make use of niche indications in combination so that we can optimally support patients.
Nice. So you started with renal replacement therapy, added therapeutic plasma exchange, couldn't quite get what you needed, and then fused it together with albumin-assisted dialysis.
That is correct.
So lots of information that we're going to unpack further in today's conversation. Maybe before we get into the meat of the conversation, any relevant conflicts of interest to disclose?
Nothing related to hybrid extracorporeal therapies. My institution receives funding from Baxter, who is the current vendor for MARS, but that's for an unrelated research study that we are conducting. I have no conflicts of interest in relation to any of the platforms that we're going to be discussing today.
All right.
All right, Alice, you want to give us a case?
Yes. So you've got a 2-year-old boy admitted to the PICU with acute liver failure of unknown etiology. He develops multi-organ dysfunction, including hepatic encephalopathy, respiratory failure, distributive shock, and fluid overload. He's intubated, mechanically ventilated, and requires vasoactive infusions. He is listed for liver transplant. The medical team is considering using extracorporeal liver support while waiting for his transplant. So when we've got a kid like this, what is your rationale for using extracorporeal liver support?
Excellent, Alice. So very typical scenario. I will step back just for a minute and reiterate something I said a little while ago, because it tends to get conflated a lot in literature when you're reading. And it's important for all our fellow colleagues to be aware of the slightly different approach that we have to patients with critical liver failure, depending on whether this is acute liver failure versus acute on chronic liver failure. Let's unpack what that means. Acute liver failure means, as the name implies, patient has no known history of liver disease, and they present with either hepatic encephalopathy, which is pathognomonic, or they present with coagulopathy that is not attributable or explainable by any other mechanism, so attributable to liver failure. If a patient has cirrhosis and ascites, that patient does not have ALF. That patient has ACLF, which is acute on chronic liver failure. Or sometimes patients might have decompensated cirrhosis and they can come to the ICU as part of their decompensated cirrhosis getting worse and developing MODS. Acute on chronic liver failure definition is less well established in pediatrics, but for our purposes today, we're just going to assume that those patients have either a known or a suspected chronic trajectory that has been making them sick with a stigmata of liver failure for a while and not presenting hyperacute into the ICU. The reason we need to understand what type of patient we're dealing with is because Yes, we do want to recover our native organ as much as possible. That should be our number one goal. And number two goal in critical liver failure in pediatrics is always transplantation. The wait times for transplantation with ALF versus ACLF are very disparate. Acute liver failure patients wait about a week because they get listed status 1A. ACLF patients with chronic disease cannot be listed 1A. They get listed status 1B, and their wait time is substantially longer. So depending on what type of patient we're dealing with, our approach to the patient might need to be slightly different in terms of the expectations that we're setting. Having said that, the presence of hepatic encephalopathy in liver failure almost always goes hand in hand with hyperammonemia in the setting of acute liver failure. Hyperammonemia or ammonia alone is not the only mechanism, but it is very central to hepatic encephalopathy. And we have evidence, dedicated pediatric evidence, that suggests that early use of CRRT with high enough dose to be able to control the ammonia levels and not really allow hyperammonemia at 200 micrograms per milliliter or higher is associated with improved outcomes. Now, none of the evidence we're going to talk about today is going to be as robust as RCT, right? We don't really have enough of an event rate in acute liver failure and acute on chronic liver failure in pediatrics to be able to power ourselves to do an RCT. Even pragmatic approach observational trials are going to require multi-center involvement, which then leads to a lot of other confounders with non-standardization of care. So we're going to mostly be talking about single center studies that come from big centers with a lot of volume, but even then, our volumes are not going to be in the several hundreds range. We're going to be talking about a handful of cases. So whenever I say evidence, I'm going to refer to published evidence, but we also will recognize that in the realm of pediatrics, our evidence quality is not going to be of the same rigor as the evidence that our adult colleagues have access to. Now, CRRT for hepatic encephalopathy in order to control hyperammonemia has become almost a standard of care for every center. However, I will say if a center has an ALF patient who has multiple organ dysfunction and hepatic encephalopathy, getting that patient to a transplant center is a more important step than putting a catheter in and putting the patient on CRRT. The transplant center is not only going to be able to care for the patient with all the extracorporeal therapies that are needed, but more importantly, expedite the listing of the patient so that we can actually potentially have access to a life-saving transplantation, life-saving organs. We will hope that the patient will recover. Whatever the underlying insult is reversible. But none of the interventions we're talking about today are curative. They're all supportive care. Therefore, unless we can actually identify something that we can reverse, transplantation remains the standard of care. Therefore, important for patients to be referred to the centers of pediatric liver transplantation. My center is a center for pediatric liver transplantation. Many of your fellows might be working in transplant centers. Therefore, a patient like this, when they hit our ICU, will very quickly be prepared for a large bore hemodialysis catheter placement for starting CRRT. Our approach is high clearance. So we'll start our patients at about 60 milliliters per kilo per hour of CRRT dose, which is double what we would normally use, and then titrate it up to try to control ammonia. And we will use higher than what we would normally use for metabolic control blood flow in order to optimize clearance and ammonia control. Let me pause there and ask you, was the patient also coagulopathic?
Yes.
Okay. So very commonly in my unit, a patient, when they go on CRRT, and if they're liver transplant candidates, and if they have multiple organ disease from acute liver failure, they will become candidates for what we have termed hybrid extracorporeal therapy, which will mean that they will be evaluated for use of therapeutic plasma exchange, plus what we call ELS, which is actually MARS, Extracorporeal Liver Support, which is albumin-augmented dialysis. So a patient like this typically in my unit will get started on CRRT within hours of arriving in the ICU, especially if the ammonia is high and it's an ALF patient. And within the first 24 hours, we'll have the first plasma exchange tandem with CRRT. And it would be a higher plasma exchange that we would normally prescribe for other diseases. We would give a double volume exchange. And we will only use fresh frozen plasma, FFP, for replacement fluid in order to be able to replete coagulation products. As you know, liver failure is not just synthetic failure. Liver failure is not only accumulation of toxic metabolites for failure of the detoxification, purification center of the body. It's a combination of these two events, plus something we rarely think about and don't know how to support, which is the failure of a huge immune organ. Liver is a big immune organ. It's part of the reticuloendothelial system. So we try and combine CRRT and TPE early on in order to account for both the purification and the synthetic function repletion that is required for the patients. And then once we reach levels that we consider satisfactory, meaning there is no life-threatening bleeding, think about slowly transitioning over to albumin-augmented dialysis in order to be able to provide continued clearance and a little bit more homogeneous control, both for hepatic encephalopathy treatment and for cardiac failure treatment, that TPE will not on its own be able to afford, since it tends to be a finite and interrupted treatment that might lead to a rebound of a lot of the biomarkers of interest that are mechanistically important in organ failure, in liver failure.
It's a great answer. Maybe to summarize somewhat, is it fair to say that extracorporeal liver support, specifically CRRT for elevated levels of ammonia, plasma exchange to correct coagulopathy, and then albumin augmented dialysis, whether that's MARS or SPAD, is it fair to say that is essentially supportive care? That's not going to fix their underlying liver disease. It provides you time to either get appropriate diagnosis and treatment or transplant.
Perfectly summarized. That's exactly right. You know, when I started giving this talk about 10, 12 years ago now, when I first started the Extracorporeal Liver Support program here at Texas Children's, I would always say it's always a bridge to transplantation. But now we recognize that sometimes, given time, patients actually have recovery of their underlying disease and can recover with native livers. So, absolutely correct. These are supportive. They're bridging. They're only allow us to buy time until we either get to natural recovery, which is rare, or transplantation, which is much more common.
Yes.
And what does the time course of these things usually look like? Are we looking at hours, days, weeks?
Excellent question. Let me give you a little bit of a compare-contrast moment. So status 1A usually wait about 7 days or so. You are going to expect your patient to start getting liver offers when they're listed status 1A within about a day or so. But the smaller the patient, in our case, it's a young toddler, the smaller the patient, the more challenging the optimum organ is going to be in terms of size and fit. The ACLF patients, let's say this patient was a biliary atresia who had had a Kasai procedure and that had failed, and the patient had developed decompensated cirrhosis, which then led to an ACLF due to a GI bleed event. That patient would have been listed status 1B and would wait weeks. In our experience, our status 1B patients listed who were on hybrid extracorporeal therapy, their median wait time was 22 days. Contrast that to what happens in Europe. Our colleagues in Europe can list their patients with high urgency transplantation. And high urgency transplantation usually means sharing of organs across the European Union and the continent and whatever organization the other countries fall under. And typical wait time for high urgency transplantation patients, even in pediatrics, is less than 24 hours.
Wow.
So as U.S. physicians, we have to learn how to take care of these patients so that we can support them until their exit, whatever that exit is, and most of the time is going to be transplantation. Therefore, the data that is generated and shared from Europe and non-US countries, unfortunately, doesn't extrapolate very well to our experience due to the scarcity of organs and the conditions that we live under.
Yes, certainly. Thanks for that perspective. Hearing the difference between the United States and Europe certainly was enlightening. I wanted to focus in a little bit on the albumin-associated, albumin-augmented dialysis. I was coming into fellowship, all of a sudden people started talking about SPAD and MARS. I'd never heard anything about this. Would you mind just kind of unpacking that for us, how it works? What's the rationale for that?
Yeah, thanks, Zach, for reminding me, because we don't do SPAD. I don't always think about it. So SPAD stands for single pass albumin dialysis. So single pass refers to the dialysate being used once, countercurrent, in exchange with the blood and then becoming spent dialysate. So I am sure most of our listeners will be familiar with a CRRT circuit. In a CRRT circuit, the dialysate is also single pass. It is used once, flows countercurrent to the blood, and is discarded into an effluent bag and then is emptied out either into the sink or to the trash at regular intervals. That dialysate itself is very similar in terms of composition to what the ideal plasma colloid-free portion plasma water is. So it has very physiological concentration of the important electrolytes, plus a little bit more buffer in it in order to counteract the acidosis that is very common in acute kidney injury, as well as multiple organ disease associated with several different disease states. If you add albumin into that dialysate, and usually the concentration is about 4%, so add enough albumin to make that dialysate back a 4% albumin concentration, and use that added albumin as a countercurrent in the dialyzer, in the CRRT machine, that becomes single pass albumin dialysis. Now, the same thing can be done in HD machines as well, but hemodialysis machines, but it is much more difficult to wind in an albumin infusion to the dialysis machines, because dialysis machines don't use a commercially made dialysate. They generate the dialysate from their source water and the available electrolyte solution and the buffer solution, which is what we call online dialysate generation. HD machines generate dialysate online, therefore wiring albumin into it is much more difficult. So typically, when we think about SPAD, we think about a CRRT setup, at least in the United States. Now, if your pharmacy is not going to allow you to put albumin into the dialysate because of concerns about albumin being a blood product and stability and the time it's going to be allowed to be in use, as you know, albumin expires within 4 hours, whereas dialysate might actually be in use way longer than that, then a trick that many of our colleagues have used is to why the albumin solution in after calculating what the rate of it should be in order to generate a 4%, not in the dialysate bag itself, but as it enters the filter, so that the patient still gets dialyzed against an albumin-containing dialysate. What's the purpose of this sort of jerry-rigging of the existing CRRT circuit? Why do we do it? Is because, as you will remember from medical school, there are a lot of factors that control the diffusion of substances across a membrane, right? And dialysis is basically diffusion of substances across a membrane. And if a substance is too big, then it's not going to come across the holes in the membrane. The membrane, which is the dialysis filter we're using, is not going to be permeable to albumin, because then the patient will be depleted of albumin within a few passes through the filter and they would die of hypovolemic shock. Therefore, anything that attaches itself to albumin is going to be trapped on the blood side of the filter, will not go across. But everything, even substances that are almost 100%, and I'm making air quotes because almost nothing in the body is 100% protein bound, even the substances that are 100% protein bound exist in, if you'll remember from chemistry, they exist in an equilibrium. There is a little bit of a free portion as well as the bound portion. If there is more binding sites available, the free portion eventually will move down its concentration gradient to the binding sites that are made available. Therefore, if the body albumin is saturated with these albumin-bound toxins, the free portion of the albumin-bound toxins will move across because there will be more binding sites available in the albumin that we have now added into the dialysate to make it single pass albumin dialysis, SPAD. What's the downside of SPAD? Why don't we use it? It's not like we don't have CRT machines and albumin. First of all, it's very tricky to make the dialysate. Two, it's not a good idea to put albumin in the dialysate because it might actually lead to a lot of errors in terms of mixing. And it's one of the most common errors medication errors that happens in renal extracorporeal therapies if CRT solutions are customized. Three, more importantly, it's single pass. So what are we doing? We're taking a resource that is very scarce, expensive, and we're throwing down the drain. We're just passing it across at 300 milliliters, 500 milliliters, 1,000 milliliters, 2 liters per hour, whatever it is, and we're just pouring it down the drain. That is why companies and vendors have looked into repurposing that dialysate solution multiple times in order to be able to reutilize it so that the spent or waste albumin is minimized. And hence the systems like Mars. There is another system that is not FDA approved in the United States called Prometheus. And then there is a couple other systems that are not available in the United States, mostly of historical interest now, called plasma filtration adsorption systems. These systems have all looked into how can we actually either combine TPE and CRT in the same treatment and use only one machine to do both, or can we repurpose the albumin instead of wasting it every time? Can we actually make it such that we refresh the albumin and use it in order to minimize the waste and therefore decrease the cost associated with it?
Yes. So as a means of summary, single pass albumin dialysis, essentially you're using that albumin as a dialysis type fluid to, I kind of think of it as like a little sponge. Like you have albumin saturated in the patient with toxins. It gets exposed across this peripheral membrane. Your albumin in the SPAD can absorb those toxins and then essentially it goes in the trash. And it's extremely wasteful, but it is one way of giving support to these patients. And on the other hand, Mars, if I understand correctly, is that just a way of essentially cleaning that spent albumin so it can be reused again?
Mostly. I love the sponge, by the way. I'm going to use this in my lectures from now on. Love that conceptualization. I like that very much. Mars, yes, does regenerate the albumin, but it also adds one more dimension by trapping bilirubin and potentially bile salts. Now, we've understood in the recent years that bile salts are double-edged swords in liver failure, especially in pediatrics. We maybe know less about them in adult liver failure, but we know in pediatrics, a little bit of bile salts is necessary for cardiovascular health. A lot of bile salts are very responsible for the havoc that wreaks in critical liver failure. And whatever traps bilirubin also traps bile salts, which are lipophilic, are not removable by regular hemodialysis-based methodologies such as CRRT. So Mars has 4 filters. They are external liver, as I call it, and an external kidney that does most of the work. And then there is an internal figure of 8 configured albumin replenishing, recharging, regenerating system. So the patient's blood only goes through the external Mars filter, which is the biggest filter we currently use in pediatrics. It's bigger than the biggest CRRT filter, has a very large surface area, has a much higher cutoff for solute size than the regular CRRT filter. To give you an idea, the regular CRRT filter is not permeable to anything that is greater than 30 kilodaltons. Mars filter is permeable up to 50 kilodaltons. And albumin sits at 55 kilodaltons. So it's not permeable to albumin, but it might be. It's just about permeable to albumin. So it's not really going to allow albumin through, but it's going to allow a lot more stuff through than the typical CRRT filter does. The Mars filter also uses an albumin fluid, and it's not a 4% fluid like we use in SPAD. Depending on your institution, between 16% to 20% albumin solution as dialysate. So blood only dialyzes against the 20% albumin solution. It doesn't really see anything less than that. The albumin, once it flows countercurrent to the blood and it soaks up sponges, Zach, all of the bad things, then goes through 2 cartridges. One cartridge is an anion exchanger where all the bilirubin and bile salts are stripped. And the other one is charcoal. It's not a hemoperfuser because there's no blood, but it's a perfusion cartridge. So the albumin solution itself goes through the charcoal and other impurities are then stripped off the albumin. And the albumin itself is now ready to be reused. Outside of this figure of 8, there is also another loop that albumin first makes before it actually comes into the figure of 8, which is a regular dialyzer. There is also a regular CRT type dialyzer, which is like the external kidney, which is on the CRT machine, not on the Mars monitor, Mars machine. And that uses a regular filter, regular CRT solutions, and regular CRT clearance mechanisms with diffusion, convection, diafiltration, combination, etc. But what that filter is dialyzing is not the patient's blood. The filter is dialyzing the albumin solution. So the water-based clearance happens very indirectly in Mars because blood gets cleaned by the albumin solution, then the albumin gets cleaned by the regular CRT filter, and then the magic really happens inside the albumin regenerating system, which is that figure of 8 that regenerates albumin. Downside is it has a expression time, life. The vendor says it's 8 hours. We use it for 22 hours in our center. We have seen that, yes, there is some decrease in effectiveness in terms of bilirubin stripping and charcoal absorption, etc. But the beneficial hemodynamic effect we see after Mars start, which typically allows us to wean pressors and has the patient enjoy a plateau in their hemodynamic instability and have more of a predictable hemodynamic pattern, continues until we are ready to change the filter. The filter has to be changed, the whole system, the whole 4 filters come on block, and they need to be changed every 24 hours minimum. Some centers will change it more frequently, especially when patients have increased purification needs. And if you want, we can talk about how that applies to patients with intoxication.
Well, that was a fantastic overview of Mars, and I don't know if I really knew what I was getting into asking, is Mars just this plus this? It certainly is not. What we will certainly do is include a link to a figure, a diagram in our show notes and our description for more information on that. So we've talked a lot about the positive sides of why we want to use all of these therapies, CRT for ammonia clearance, plasma exchange to improve the synthetic factors, and Mars and SPAD for clearance of bound toxins. What are the risks associated with these therapies? Like, what are the downsides or disadvantages?
The biggest problem always in pediatric extracorporeal therapies is morbidity associated with access. None of these patients who are going to get themselves an extracorporeal circuit or 2 or 3 are a little bit sick, but minding their own business and maybe hepatic encephalopathy stage 1 to 2, a little cranky, difficult to console, but still sitting on the floor eating pancakes. And these are very sick kids with life-threatening illness, to the point that we can justify putting a large bore dialysis catheter, dual lumen dialysis catheter in a large vessel. Now, the smaller the child, the trickier this gets. The smaller the child, the riskier it gets. So we prefer that patients have the most experienced and skilled operator available in order to place the catheters. The resuscitation catheters we use in pediatric critical care is 4 French, 5 French, maybe 7 French, depending on the size. That is, might be an adult size patient. But our smallest dialysis catheter that we can run CRRT, tandem TP, and Mars on will be an 8 French. And most of these catheters are also very rigid and long. So there is potential vessel shear and organ injury, penetrating injury, as well as bleeding and clotting associated with the catheter use. Now, if a patient needs these therapies, a patient needs these therapies. So recognizing all these potential risks, we will still put the catheter in. There is some nuances that we need to think about when we're using each therapy. And those typically relate to anticoagulation, one, and two, depending on the size of the patient and the size of the filter, dilutional coagulopathy. So let's talk about those two things. In the past, a lot of the centers thought that liver failure patients would have coagulopathy, therefore they can be run on extracorporeal therapies without anticoagulation. However, we have now found out that the coagulopathy in liver failure, especially in ALF, is what's called a balance disturbance of hemostasis. So yes, we have a shortage of clotting factors, but a lot of the natural anticoagulant factors such as protein C and protein S are also made in the liver. So surgeons will tell you ALF patients, even with INRs of 6, 7, 8, don't bleed when they have surgical incisions because their homeostasis is rebalanced at a different level. So their numbers might look completely off and terrible, but they still will lack both things just enough that their bleeding risk might not be as bad unless they're also thrombocytopenic or they have another risk factor such as a stress ulcer, GI bleed, etc. ACLF patients, acute on chronic liver failure patients, almost always have splenomegaly because they have portal hypertension. Those patients will have thrombocytopenia and they tend to bleed. And anticoagulation is very much required for both patients, but with a very careful approach to monitoring as well as avoidance of systemic anticoagulation when possible. We use regional citrate anticoagulation as the first step for any anticoagulation for both CRRT and TPE in our center. Many centers will follow our approach in the US, but there is some centers that have started using prostacyclin as a platelet inhibitor in order to anticoagulate their circuits, even in liver failure patients with success. However, utmost care needs to be shown to make sure that patients are not really very thrombocytopenic, meaning platelets are not less than 20, very hypofibrinogenemic, fibrinogen less than 100, 150 even, and there is no life-threatening bleeding because all of these things all together might actually make us redirect and do another session of TPE for these patients instead of doing ELS, for example, or MARS for that day. We might just do TPE in order to be able to fix their coagulopathy. I know it seems counterintuitive to what I just said, but if there is life-threatening bleeding, regardless of whatever theoretical approach we have and we believe in balanced hemostasis, etc., life-threatening bleeding needs to take precedence and we have to address that. And CRT plus TPE will address that to the most satisfactory results in many of the cases. Another thing associated with anticoagulation, which will always be associated with TPE use in liver failure patients, it's citrate load. So citrate is metabolized through the liver. If patients don't have liver function, they can't metabolize citrate. And citrate accumulation manifests itself as quickly dropping ionized calcium levels in the face of either stable or rising total calcium levels because citrate chelates calcium, and that's how it actually achieves anticoagulation by depriving the body of very necessary steps, calcium, for coagulation cascade in multiple steps. But also, there is a lot of citrate in FFP. So it's not just the citrate that is used in citrate anticoagulation, regional citrate anticoagulation, but the amount of citrate that the patient is exposed to because of the large amounts of FFP that is used in TPE, that the patient needs some sort of clearance. The good news is citrate is a small molecule. Calcium citrate complexes get cleared very effectively in CRRT. And that's one of the reasons we tend to utilize a higher dose of CRRT clearance in order to minimize citrate accumulation and citrate toxicity. But if a patient is developing metabolic acidosis and lactic acidosis frequently with disparate and rapidly divulging total calcium and ionized calcium values, that is citrate intoxication, citrate toxicity, and that requires urgent interruption of the citrate that is being used for anticoagulation. So very rare, has to be recognized and immediately and rapidly treated.
Wow.
Do we have time to talk about the dilutional coagulopathy aspect of it? Because that refers to MARS.
Okay. Oh, absolutely. Yeah.
Okay.
If you have time, we have time for sure.
I have time. Don't worry. I blocked my afternoon for you. So thinking about the Mars filter, because it's the largest filter, remember, even if we blood prime it, we're going to blood prime it with red blood cells, maybe constituted with albumin, maybe constituted with saline, reconstituted to a hematocrit of 35%, depending on the institutional preferences. But fibrinogen partitions to the intravascular space. So if we actually use an extracorporeal circuit that has 10 to 15% at least the patient's circulating blood volume trapped in it, then there is going to be a proportional decline in fibrinogen. Now imagine, let's say your patient is 10 kilos, the patient that we had the vignette on, and the estimated blood volume is 700 cc's. The Mars extracorporeal volume is going to be about 20% of that patient's estimated blood volume. So there's going to be a 20% dilution in terms of the fibrinogen and platelets, as well as there's always some activation of platelets and some trapping of fibrinogen that happens whenever blood is exposed to a foreign surface, even when you anticoagulate the patient fully. So there is a drop in platelets and fibrinogen that happens in the smallest patients, especially patients with a lot of endothelial activation, especially when small patients who don't have a monitoring surveillance in place in terms of hemostatic parameters and a replacement protocol in place, either with intermittent TPE periodically or with blood product perfusion. Small patients on a Mars circuit, the ones who are less than 10 kilos, are at very high risk of dilutional coagulopathy and bleeding risk. Therefore, I would recommend extreme caution in using it in patients who are less than 10 kilos, specifically ELS. In less than 5 kilos, it is almost impossible because of how big the filter is and how much fibrinogen platelets get trapped into it. We've successfully used it in 2 patients. One was a 4.5 kilo patient. The other one was a 4.8 kilo patient, but was pretty much a nightmare. I maybe shouldn't have said successfully. We used it, period. And they both got transplanted, but that has become the lower limit in terms of inclusion in our institution now. If a patient is less than 5 kilos, we will stick to CRRT and TP and not necessarily do ELS. And let me say something that I think should be the only takeaway from this podcast, in my opinion, despite me singing the praises of the Mars system and the albumin-assisted circuit. There is very good evidence, actually RCT level evidence in adults, that has shown that in acute liver failure, high volume plasma exchange, in addition to standard medical treatment, decreases mortality and morbidity and might actually improve hemodynamics. So if any patient of ours who is 18 and above, who is an adult, should get high volume plasma exchange. That's category 1 now per the American Society of Apheresis recommendations, ASPHA recommendations. And anybody who is 16 and older should get an evaluation for whether they should get high volume plasma exchange. I would highly recommend that no liver failure patient gets high volume plasma exchange without CRRT due to citrate exposure and toxicity. But if a system is a liver transplant center and they have CRRT and they have the ability to do TPE, I think for what we know currently from an evidence standpoint, those are good enough for us to be able to provide augmented clearance and advanced blood purification to our patients of all ages without really having to go out and invest in a specific device, such as Mars or Prometheus or one of the other devices. If you have it, it's wonderful. I think it does have its niche uses. But I think the profile of what we're able to offer liver failure patients from an ELS standpoint, from an extracorporeal liver support standpoint, is going to evolve. Mars is not manufactured anymore, that specific platform. It's still supported by the vendor. It will be available and around for another maybe 7-8 years or so. We do anticipate that we're going to have newer platforms that come on the market. Whether they're going to be quickly FDA approved and available to us in pediatrics, who knows? My guess will be no, since children tend to get disenfranchised in our field, unfortunately, since our numbers are small. But at least if there is an adult platform that's FDA approved, it gives experts the ability to use it off-label, like we do with most of our machines. Most of the CRRT machines are used off-label as well. They don't have specific FDA approval for less than 20 kilo patients.
Yes.
Wow.
I really appreciate you putting that finer point on the take-home point for thus far in our conversation. And then when you were talking about the issues with coagulopathy and citric toxicity, I was taken back to rounds for a little bit there, thinking about all the worrying that goes with all of these patients. Goodness, they are so complex and so fragile. And that's why it's so important that we talk about them today. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.